And to continue in our theme of psychopharmacology, I'm very pleased to be able to introduce to you my friend and colleague, Dr. James McCracken. Jim is the Joseph Campbell Professor of Child Psychiatry here at UCLA Semel Institute. He's also the director of the Child and Adolescent Psychiatry Division and the director of our Child and Adolescent Neurodevelopment Clinic, which is part of our Center for Autism Research and Treatment. And Dr. McCracken, as you probably all know, is one of the leading international experts on pharmacology and clinical trials in pharmacology and autism. So please join me in welcoming Dr. McCracken.
Thank you, Susan, and afternoon to everyone. How are you all doing? Good. Good. I was going to say something silly like, it's great to be back in LA, or something like that. Well, what you just heard is the really important stuff about the use of medications in the treatment of autism. What I'm going to review with you now is really kind of a teaser about what type of treatment development is taking place that perhaps foreshadows what treatments we'll be using 5-10 years down the road. But I say it's a teaser because many of these things are just simply not going to pan out in the way that we hope or think they might. But my main message is that there is a lot of hope and a lot of encouragement about finding new biomedical treatments that by themselves aren't going to be sufficient treatments for ASD, but together as a part of a comprehensive treatment approach, we believe can make a more fundamental difference and improve long-term outcomes. So why should we keep pounding our heads against the wall trying to find new medications that are superior, safer, or that target areas that continue to be vexing? Well, perhaps the main reason is that we know, and this is in a lot of ways relatively recent information, as we followed children diagnosed with autism into young adulthood, and in some studies into middle adulthood. Kind of dangerous for me to start talking about designations like adulthood, but anyway, what we've learned is that autism and its cardinal features are very, very stubborn. And that is despite the fact that we know that early intervention and intervention beyond early childhood is much, much more available now. But it, to be honest, hasn't made quite the major impact in those longer-term outcomes as we had hoped. And in some ways, that's even most painfully encountered when it comes to following relatively high-functioning individuals on the spectrum, where you see these folks in their 20s, 30s, that perhaps we know have IQs of 120, 130, who are simply unable to finish university, unable to hold down a full-time job, and who are living lives of relative isolation. It's all too common, and that's the best case, of course. So that's what spurs us on with the kind of work that I'll be talking about today. And another thing I want to highlight is that increasingly, as we're thinking about the use of medications, we are incorporating other targets, you might say, other functions or difficulties above and beyond the core social communication weaknesses and the problems of repetitive restricted behaviors and sensory hypersensitivity, to include things like the common cognitive weaknesses that we identify in people on the spectrum. And this includes people who may be scoring in the above average or superior range, where often we see these holes or these relative weaknesses that form challenges for them. We still know that IQ is often depressed in individuals with ASD. And we think that it's not crazy to believe that if we understood the fundamental cause, that we might be able to help improve cognitive functioning, kind of along the same lines of thinking as the notion of cognitive enhancers that you may have heard about. And so even though formal intellectual disability rates among people with ASD have now dropped considerably, well over half from when I was taught as a little child psychiatrist years ago, now 30% of individuals with ASD who were more recently diagnosed still meet criteria for intellectual disability. So cognitive weakness is definitely a major issue. So as Dr. Snyder just described to you, in a way you could challenge us for simply doing research around the edges of autism. By that I mean we've been working hard and have achieved relative success at learning about things that help with the hyperactivity, with the aggression, self-injurious behavior, a little bit with anxiety. But we haven't really been brave enough until just recently to start thinking about aiming medical treatments at these core deficit areas: communication, social interaction in all of its forms, and repetitive restrictive behaviors. That's what we now want to take on. So to kind of set the larger context for you, I think from most people's perspective, no matter what side of the issue you're on, whether you're a parent or a clinician or a researcher, it's fair to say that the overall pace of the development of biomedical treatments has been way too slow. One measurement of that is just looking at what treatments, like Dr. Snyder described, have been fully approved by the FDA for use in kids and teenagers with ASD. There's only two, and the last one, the most recent one, was granted in 2009, almost a decade ago. So that's painfully slow, especially if you're sitting there with a 6-year-old and waiting for treatments to come forth, right? The other aspect, above and beyond medications per se, that has lagged behind is investigation of devices or non-drug treatment. I'll give you some examples of that in a moment, but there's been too little of that going on, although I'm going to suggest to you that that's changing. Now, on the positive side, our friends like Dr. Geschwind and other basic scientists have really been incredibly productive and effective in helping us to begin to develop a notion or some models of what the biology of autism might consist of. And once we have that, that's going to be very helpful, we believe, in identifying new and even better treatments. But in a way, they've almost been too helpful, too productive, too good at what they're doing, because as we're finding out, ASD is in fact a very, very complicated set of conditions, and no one medication or no one treatment should ever be expected to have universal application in ASD, because people are so different, even those sharing the diagnostic label. So don't get down, though, because relatively recently, including one event just in this January, there's been some promises indicated by the Food and Drug Administration and their evaluations of current studies involving different medications. For example, I'll talk about the FDA's designating RG 7314, a new and novel medication, as a potential breakthrough therapy for autism. Pretty cool. That's the first one ever designated in that manner for ASD. And then also there's another designation that the FDA uses, essentially showing promise as well, called a fast track designation. And I'll describe that also, again, another novel biological mechanism. And then finally, I'll talk a little bit about a whole new area, really out of the box, which is at least thinking about the application of neurostimulation for autism, something you all may have heard about. So there has been a lot of work going on in this area, and there are several promising compounds. That's really my main message for you today. But despite a lot of super smart people and a lot of prior research, some really great looking ideas and medicines simply flat out failed so far, going back now about 5 to 7 years of this new generation of studies really trying to get at the core features of autism. And that's led us to try to think even harder about the mechanisms that may be underneath autism and how to address them. But we are making some progress, and I have to say, in some places it's been surprising. Now, you've heard a lot about oxytocin, I'm sure, and this is probably the best studied, non-approved experimental treatment right now. There's over a dozen studies of oxytocin. The problem with those studies, for the most part, are that they're way too small. They have a nagging tendency to each choose like a different goal or a different measurement of its effect. So in some studies, it's measuring the subject's ability to label a face, label the affect, the emotion of a face. How many minutes is that, dear? 15? Oh, thank you. She knows my bad habits. So in other studies, as in this one, they declared themselves to prove that oxytocin is going to reduce repetitive behaviors. And the effect was weak at best. That said, the National Institute of Health supported a major study 10 times larger than any existing study to date, which just finished about 3/4 of the way through 2017. And we're waiting with bated breath to find out what the results are. That will be the definitive study of oxytocin, whether we can use the little emoji thumbs up or thumbs down. It really will be that important, I think. But right now, there's no leaking to the press. There's no memos being put forth. So honestly, we do not know what the results are. One of the positive aspects of that study, contrary to almost everything else in the literature, is that they included younger children down to about age 6, and they also included lower functioning children and teenagers. Almost all of the other oxytocin studies just stuck with high-functioning, bright subjects. And so that's a big limitation. So I'm going to review these 5 other areas here as to what's new. The first has to do with going back to study results that have already come out. This is a study that Dr. Snyder talked about that we were involved in which we were testing Guanfacine, a commonly used medication for ADHD, and testing its effectiveness in kids with autism as well. And we did find that the Guanfacine was associated with a superior reduction in ADHD symptoms compared to placebo, which was great. And we were really impressed that the benefit of it seemed almost exactly the same as what we had found in the Ritalin study that preceded it. The other aspect that was important in those results was that it seemed to be a little bit better tolerated. We didn't see the kind of irritability, the big sleeplessness problems that we saw in some kids with the Ritalin study. But then we went back and looked at other measures that we'd collected. And this is not an entirely fair way to do research, but it's a way of kind of pointing towards clues. We had some measures of repetitive behavior called stereotypy in one of the rating scales that we love to administer. And what that showed was that comparing the baseline rating of these repetitive behaviors and movements to the same measure score at the end of 8 weeks showed a significant drop versus placebo in those mostly motor movements. Placebo dropped some too, but this was statistically significant. And as you can see, it's almost like a 50% greater drop in the drug-treated kids. That's not enough to say, hey, let's try Guanfacine for repetitive behaviors, but if one is in a pinch, if those behaviors are just simply impossible to address using behavioral strategies, it may be something to consider. And we did show that it was a medicine that's been found to be very safe overall and well tolerated. Now, many of you will encounter physicians who seem to focus quite strongly on what one might call complementary and alternative treatments for ASD. And that includes the use of megavitamin or high-dose vitamin treatment. This is one example of the results of a well-done study that leaves us just annoyed by the uncertainty of the finding, which is true in many of these studies. But the premise of this study is that a deficiency in the vitamin folic acid, the B vitamin, which is crucial for good nerve and brain function, is associated with ASD much more commonly than in the general population. And thusly, that if we supplement folic acid or folate, then perhaps we'll see behavioral improvement. Now, the problem is that if you take like a whole bottle of folate that you got from CVS, almost zero of that will get into your brain. Sorry to tell you that. However, there is a different form of folic acid or folate called folinic acid that does cross the blood-brain barrier much more effectively. It's actually used a lot in individuals receiving certain cancer treatments where the cancer agents deplete folate, and you have to really make sure that they don't get into a folic acid deficiency. So this folinic acid, CVS doesn't sell it over the counter, you got to get a prescription, has been tested now, and in this particular study was published in Molecular Psychiatry, one of the preeminent journals in psychiatry. And it was touted in the abstract to say that folinic acid showed efficacy or benefits in a variety of areas in the treatment of individuals with autism. That's great. But those of you who, like me, like to sit down at night with a stack of journals by the bedside table, and you start looking at some of the tables and graphs a little more closely, like in this one, you find that, okay, the biggest effect that folinic acid, according to the authors, had was on language variables. So then, to their credit, they put out a lot of information in this paper, but one of the graphs showed the Vineland adaptive behavior scales, commonly used measure of kind of the daily skill level of individuals, and it has a communication scale on it, which is sort of like real world ability to communicate, right? So did folinic acid change that? Well, maybe your eyes are better than mine, but there's just no difference there, which it just leaves me in this chronic annoying state now. However, and I'm not trying to dismiss this, what it may suggest to us, and this is serious business, there may be a subgroup of kids who have a central nervous system deficiency of folate who might benefit a lot from this. But hey, guess what? The only way of identifying that right now is a spinal tap. Come on and let's measure your folate, right? No. So we need to find some other means to identify those kids who will benefit more. So Dr. Snyder showed you this study already. I won't belabor it. It just identified that, lo and behold, there were some social benefits to this low-dose stimulant in those kids who were really hyper on the spectrum, and it also helped them regulate their emotions better, which is a good thing. So this was studied in 2009. We're starting a study that represents the follow-up to this, because our interpretation of this study is simply that lower levels of dopamine in the brain perhaps have a good bit to do with the apparent lower social interest or enjoyment that many individuals on the spectrum have, especially in social interactions day to day, but perhaps also in response to other kinds of presumed rewards. This is the only way we think to figure out if indeed pushing dopamine functioning will be helpful or not. We're going to focus on kids, teenagers, and young adults. And we're doing this with the amazing Dr. Laugesen, the amazing Dr. Buchheimer, and the amazing Dr. Bott. We have a great team. We're testing whether or not the good old-fashioned L-DOPA, which in a way you might think of as a kind of supplement used now for decades in Parkinson's, in kids for restless leg syndrome, even been tried as a treatment for childhood amblyopia, so with a good safety track record, might help these individuals going through this social skills training program to enjoy it more, to gain more from it, and end up at the end of 16 weeks showing even better social skills. We'll see. Now, maybe one of the most exciting bits of news, is this breakthrough designation that I mentioned to you earlier. This is a medicine being developed by Roche Pharmaceuticals. Disclosure, I've worked with Roche as a consultant and been a part of some studies, although with an earlier version of a medicine that worked in the same way, but not this one. But I have no skin in the game otherwise. But this is a really interesting and novel treatment. Just in January, the FDA said, this study looks positive enough that we're going to try to help you test it, and if it works out positively, we're going to try to help you get it to market faster. Usually that can take from this point to actual marketing as long as 2, 3+ years, sometimes even more. This may shorten it to perhaps even a year and a half. So what's interesting about it is that it's kind of like the opposite of oxytocin. It's very confusing in some respects because it binds to some of the same receptors or parts of the brain that oxytocin binds to, but this time it blocks it. It doesn't act like a supplement or extra. But the major thing that led the FDA to say, hey, green light is, so far, is their vanilla study that just finished. 223 male adults with ASD. They looked at changes over 12 weeks, which maybe seems like a long time to you, but obviously in the life of an individual is a short time. Fortunately, there were very minimal safety concerns that emerged, at least from the observations obtained. And what they saw was, and a little bit contrary to where they were looking first, which is more irritability and things like that, they actually saw improvements in some measures of social functioning and in communication, measured by that Vineland thing again, which is interesting. Now we've got a positive signal. They immediately started a child study that's almost completed, so we'll have data from children and adults. And to get over the hurdle to a full approval as a marketed treatment, they need to complete at least one more positive study. And this study, a so-called phase 3 study in adults, is starting this summer, and we're going to participate in that. So I'm going to finish up here. I'm sorry, running just a tad over. What about neurostimulation in autism? Is there a role? Now, this looks like a comfortable treatment, right? A nice, cozy dental chair sort of apparatus with a friendly physician holding a magnet over your head that kind of beeps and snaps and gives you tingles. This is transcranial magnetic stimulation. It is approved for the treatment of really, really stubborn depression, but nothing else at this time. There are a few proponents around the country, probably list them on one hand, who believe that TMS might have benefits for autism. Now, a couple of us who, at least for me, it's totally outside of my area, we've been reviewing this literature and the knowledge that's related. We published this summary not too long ago. I think the main thing that we felt we could conclude is that at present, there's no indication of a safety problem with TMS in kids based on reports of kids, over 400 children receiving various kinds of TMS stimulation. But we also felt that there's no evidence to support its benefit at this time. It is a research treatment at present. But that doesn't stop some people. There's a fellow in Louisville, Kentucky, who is a big believer. And they published, this is one of the few studies in kids with autism that has measured kind of a relevant behavior. In this study, they gave these adolescents, they randomized them to either a wait list or the active treatment and gave them the repeated sessions of TMS. Basically, their main finding was that those that got the TMS showed reductions in irritability, most prominently, and repetitive behavior. So what's the problem here? Why aren't we just running and setting up our TMS ASD treatment centers? Well, if you're in a wait list, you're not getting any treatment at all, right? And if you're in the TMS group, you're getting the shock like 5 days a week. So there's no blindedness, and you just can't subtract out that bias. I think this deserves more study to be sure, don't get me wrong, but it's not an easy treatment to be tolerated. There are some other ways of neurostimulation, however, that are easier and can be applied in children. This is another one called trigeminal nerve stimulation. And indeed, you wear the electrodes as you sleep. It's not painful. My colleague Jim McGuff has finished 2 studies now with its effects on ADHD, showing benefits, including in a follow-up double-blind controlled study. And so we're going to start a study here at UCLA of the TNS for similar kinds of problems in kids. Lastly, 2 more examples of novel and promising treatments. In this case, this is a hormone treatment called insulin growth factor 1, applied in Rett syndrome. Now, Rett syndrome is a terrible condition. It's very severe. It leads to just profound regression in skills across the board. In some ways, it might be the hardest syndrome to treat, period. And yet the FDA felt like this deserved at least fast track designation because of results like this, in which parents reported that children receiving the highest dose of the insulin growth factor showed greater benefits than the placebo group. And it also has shown benefits in another pretty severe syndrome, Phelan-McDermott syndrome, or SHANK3 deletion syndrome, as shown here. And then lastly, you might have heard about cord blood infusion or stem cell treatment. These are not the same. Importantly, this is blood stored from the umbilical cord at birth, given back to the same child, not a stem cell treatment. This looks pretty good in, again, an unblinded study. So all of these people knew what they got, a 1 cord blood infusion followed up over a year, really looking at safety. This looks pretty positive, but then when you break out those by intellectual level, low functioning in blue versus high functioning, it's another case of the rich appeared to get richer. The lower functioning kids just didn't move. So this is going to be studied in a blinded form. Let's hope that it works, but right now we're in that annoying state of uncertainty that we live in. Suffice it to say, there's a lot going on in a lot of different areas, and I think we're going to hit on things that are helpful eventually. So bear with us. Thank you.